on Understanding Female Infertility, where we are going to try and find and understand the causes and possibly treatments of female infertility. But first, we want to know, when are you labeled as infertile? And if you're unable to conceive after 1 year of unprotected, regular, frequent intercourse, then you definitely need to see the doctor. And by the word unprotected, I mean no condom. Regular, I mean having sex, say, every alternate day. And if you are having this during your fertile period, you are aware of your fertile period, then all the more reason that you need help if you have not conceived. Your fertile period in a normal 28-day cycle is day 8 to day 18. If we take day 1 as the first day of your period, certainly you're not alone in this. And there are about 10 to 15% of the couples who have not conceived a pregnancy even after 1 year of intercourse. So when should you see your gynec? You should see your gynec if you're unable to conceive after 1 year of unprotected regular intercourse, if you are younger than 35 years of age. You must see your doctor earlier if you are 35 to 40 years of age and you have been having donor insemination which has been timed to your egg release. And even earlier, between 0 to 6 months, you need to go back to your doctor if you're more than 40 years of age, you have a previous history of infertility, previous endometriosis, inflammation, more than 1 miscarriage, and previous cancer treatments. Now, can your husband be responsible for this? Yes, certainly. If you are responsible for infertility of the couple in 30% of the patients, then your husband is responsible in 30%. You both have some reason, both your husband and you have a reason for there to be infertility in 10%, and in 25% it is unexplained, which means that we have not been able to find the real cause even after investigations. Many of these are endometriosis and they require a little different management. So when should your husband visit the andrologist or the doctor who is responsible for the male infertility? If problems are detected on semen analysis, if there's a swelling in the scrotum, previous surgery, small testes, impotence, lack of libido, and a previous cancer treatments. Now, let's have a look at the female reproductive system. This is the internal female genitalia. Now, we know that this is the uterus and this is known as a cervix. The uterus is also the womb in colloquial language. Cervix is the mouth of the uterus. These are the tubes, and then you have the ovaries. So the problems could be anywhere in this entire internal genital tract, or it could be in the hormonal control of ovulation. By ovulation, I mean by egg formation and release. So problems in egg formation are most classically in the syndrome polycystic ovarian syndrome, known as PCOS, where there is no egg release, there is late irregular periods, there are certain male features like facial hair, and there are cysts in the ovaries. Then there could be other hormonal problems like an increase of prolactin, where you could find you have a breast discharge even though you haven't had a delivery in the last 1 year. So then why should there be a breast discharge? Excessive exercise and weight problems and eating disorders, and any form of stress, which could even include mental stress, which can prevent the egg from releasing. The cervix or the mouth of the uterus may be very tight or closed. The uterus may have an abnormal shape either from birth or because of fibroids, and the tubes may be damaged or blocked because of sexually transmitted infections, endometriosis, adhesions, tuberculosis. The commonest cause, if you can see from this here, is that the commonest cause of female infertility is ovulatory disorders. This you can have a look at the polycystic ovaries, where there are multiple fluid-filled cysts or balloon-like structures in this ovary. This is an ultrasound picture. And the second most important cause of female infertility is some problem in the tubes. Now, understand what the tubes are meant for. So, if you look at this diagram, this is the uterus and then this is the tube. Now the tube, the far end of the tube will actually pick up the egg from the ovary, and that egg travels down the tube, and here you have the semen or the sperms deposited in the vagina, which will ascend into the uterus and enter the tube. So the meeting of that sperm from the husband and with the egg happens in the tube. This is known as fertilization. So you have fertilization occurring in the tube, and if there is any problem in the tube, obviously the sperm cannot meet the egg, so there will be infertility. You will not be able to conceive. So what could be the causes in tubes? Any kind of inflammation or infections, pelvic inflammatory disease, sexually transmitted infections, or tuberculosis is another very important cause. Or if you have had unhygienic conditions at delivery or even a septic abortion, or you have had some trauma or some to the tubes. For example, a previous tube pregnancy is not normal, so that was damaged because of that tube pregnancy, or any surgery in the uterus, around the uterus, outside the uterus, like an appendix, which can cause damage to the tube in that area. So these causes an adhesion to the tube. One of the most important causes, at least in our country, the causes for infection and infertility is tuberculosis. It is also called in short as TB. So the organ which tuberculosis affects the most is the fallopian tubes. Then it is the lining of the uterus. So what we are seeing is that the most important effect of tuberculosis of the genital tract is blocked. The lining of the uterus is destroyed. So because the tubes are blocked, fertilization cannot. And if fertilization, okay, So how will you know that possibly you have genital tract tuberculosis? Now see, if you are in India, cause of infertility, which is endometriosis. You want to know why, how, what. Now look, whenever there is a period, this is the lining that I'm pointing to, this red line which is inside the uterus. Every time there's a period, it is this lining of the uterus, blood and tissues which will shed outside. Now, in certain situations which you do not need to go into what are the causes, why it happens, but sometimes this lining does not shed out in this direction. By a reverse kind of a contractions of the uterus, this lining enters the tubes and then comes out in the abdomen, and these blood cells and tissue cells spread all over the abdomen. This is known as endometriosis, and this name is taken after endometrium, which is the name which we give to this lining of the uterus. It's because this endometrium or the lining of the uterus is outside the uterus that this condition called endometriosis is made. Now, when we do a laparoscopy or put telescope inside the abdomen, when we look at these powder burn spots, or we see some yellow blebs or white blebs or chocolate colored fluid coming out either from these or from the ovaries, or there are some adhesions, then these are indicative of endometriosis. And of course, there is scar tissue or adhesions which forms between all the organs in different stages. So the size, it can be anywhere outside the uterus, sometimes in patient arms also, and even the umbilicus. So in the pelvic cavity, it can be anywhere, but most commonly it is in the ovary, giving rise to chocolate cysts of the ovary. It can vary in severity, but the point that I want to make is that even mild or minimal endometriosis can be associated with as bad infertility as a very severe stage or a grade of endometriosis. Now, how would you know, like, that you possibly have endometriosis? The most classical symptom is pain before, during periods, and even persisting after periods. Pain at the time of intercourse, pain during periods, during urination, during bowel movements. So pain is a recurring issue. Then heavy bleeding is another symptom of endometriosis, and of course, infertility. You must realize that one half of infertile women have endometriosis. Endometriosis and infertility is so closely linked together, and cases are there, then it that 50% of them, up to 50%, are likely to be infertile too. So how would you treat it? Normally, the definitive treatment of endometriosis, we say, is removing the ovaries, because the hormones produced by the ovaries actually increase the size of the endometriosis. So if you're removing the ovaries or the tubes and the uterus, but in a woman who is infertile, why would we want to do this? We don't want to do definitive treatments of endometriosis in a woman who wants to have a baby. So our job is to conserve as much as possible, which means that we don't want to remove the uterus, tubes and ovaries. Now, infertile patients with endometriosis, the gold standard treatment is to do surgery, not to take medicines. Medicines can decrease the size of the chocolate cysts by around 40%, but not more than that. So surgical treatment is the gold standard, and if you have a choice, then laparoscopy method rather than open method is the gold standard. So at laparoscopy, what we do is to release as much as adhesions as possible, remove the endometriotic cysts, and burn those areas which are active so that they do not cause any more adhesions in the future. You must not forget that if you have had laparoscopic surgery for endometriosis, then you must conceive within 1 year. Don't waste your time. Because if you just hang around wasting your time, then these adhesions will form again and you might require a repeat operative laparoscopic procedure. Other causes of infertility could be other causes of adhesions also, or menopause, when you know that periods stop, the ovaries have stopped functioning, and there could be hormonal problems like thyroid or medical problems, cancer and its treatments which are destroying the ovaries can also cause infertility, certain medicines and certain genetic or congenital abnormalities. So what would be the risk factors? Which people are more likely to have infertility? Age, weight issues, too much of exercise, too little of exercise, smoking, alcohol, drugs. Of these, age is one of the most important factors for infertility. In fact, we have so many markers to find out how fertile you are. And out of all those markers, the latest recommendations suggest that the best surrogate marker to know about your own fertile status is age. Fertility is maximum below 35 years of age, and as age increases, you will find that infertility also increases. Age not only impacts whether you have ease in getting pregnant or not, but it also influences miscarriage rate. There is increased miscarriage rate with advancing age. There is increased risk of ectopic, and there is increased risk of abnormalities of the baby as your age advances. So other than that, we have weight issues, either over or under. Definitely, obese women have about 3 times more chances of being infertile as compared to normal women. So you should be able to do your own weight and your body mass index calculations. You should know where you fall. You can calculate your BMI by weight in kilograms divided by height in meters square. You can see this chart. We have this underweight and the normal weight, the overweight and the obese. But for Indian population, all these figures, you must subtract 2.5 in each category. And you should be concerned if your BMI is more than 23. Try as much as you can to have your BMI below 23 for there to be no hormonal problems which will impact your fertile status. So now you have a general idea about infertility and you plan to visit your gynec doctor. What is the information that you should carry? Don't remain blank, because this is the information which is very useful for your management. You need to tell your doctor how long you are infertile, since how long you are married, since how long you have been trying. Are you aware of your fertile period? How frequent is your intercourse? Is your husband on a touring job? Is he available during your fertile period or not? Have you had any problems during intercourse, like a premature ejaculation or a lack of libido or a desire? And you must also carry with you your menstrual dates. When did your period start over the last 4-5 months? Tell your doctor about your previous pregnancies and the interval between your previous pregnancies. Did the interval, was it more than 1 year since you were trying? Did you have an infertility in the past? Tell your doctor about any medical or surgical problems, and tell your doctor what medicines you are taking. In fact, if you are taking medicine prescribed by another specialty, carry those medicines, but because your doctor is not expected to know the trade names of all the medicines that you are taking. So carry them so that your doctor can do a cross-check to see which of these can cause infertility. A little explanation of some of these special tests for infertility. we are going to test you for hormones as well as progesterone and ovarian reserve. Now, what exactly is ovarian reserve? We want to find out how equipped are your ovaries to produce eggs, which will ultimately land up in a live birth. Now, as you age, your ovarian reserve may be much less, and in case it is not a very hard and fast rule, if you have a poor ovarian reserve, like some young women may have a poor ovarian reserve, but the quality of their eggs may be very good. But it's not as if you have a poor ovarian reserve, then surely there will be infertility. It's not a hard and fast rule. It just says that don't delay. Think that if your ovarian reserve is showing low, then there are chances of it being even shorter than what your tests are saying. So don't wait for any time period beyond that. Of course, antral follicle count also helps in finding out your ovarian reserve. Follicular monitoring to see the growth of your follicle. Hysterosalpingography to check the patency of your tubes. Hysteroscopy is endoscopy inside the uterus. Laparoscopy is endoscopy outside the uterus. And of course, very important is the husband's semen analysis. So here you can have a look that the hysteroscopy is done from the natural passage below. So there are no cuts. And this is a picture of what the uterus looks inside. And you can of course visualize if there's a large fibroid here, or there is a septum here, or there are adhesions inside this. Everything can be seen and operated upon with great ease. This is laparoscopy, where the telescope is put in the front of the abdomen with small 0.5 centimeter instruments inside with which we operate. So now coming to the fertility cure and treatment. You may require antibiotics for infections. Of course, if there are any hormonal problems, sugar or blood pressure that needs to be controlled. You may require to take some medicines to cause release of the egg, or certain hormones to cause release of the egg. And sometimes you require an artificial insemination, intrauterine insemination, either with husband's semen or from a donor semen. Now this will help to overcome some semen problems, or if cervix, the mouth of the uterus is very tight, so that tightness can be overcome. IVF is required if there is a problem in the tubes, then you know that fertilization occurs in the tubes. So you can have fertilization outside in the laboratory, that is in simple words IVF. And ICSI. ICSI is whenever you are injecting a sperm directly into an egg. In case there is some problem in the uterus, for some reason it is not okay, then you can even go in for surrogacy, in which the egg is yours, the sperm is your husband's, but the womb or the uterus is of another woman. Now this is a small picture to explain intrauterine insemination, where the semen is washed and prepared and concentrated and bypassed the cervix to place directly inside the uterus. In IVF, we take out the eggs from here, this is known as ovum pickup, and we put it in a petri dish, and we have sperms which we add to this. This is what it will look like, a lot of sperms. And once the fertilization occurs, then one or two of these fertilized eggs are transferred back inside the womb. So the fertilization is occurring outside because of some problem in the tubes. Now in this is the egg. We are injecting a single sperm directly inside the egg, intracytoplasmic sperm injection. This can usually help if there is failed IVF twice, or if there are certain problems in obstruction, these sperms are not being released outside, so we can take them directly from the testes or from the tubes in the scrotum. Indications for IVF: you need to go to your gynecologist and good enough to manage medicines or hormones to release the egg. and to do an artificial insemination if required. But if you require further advanced treatments, you need to go to the IVF or infertility specialist. In case there is any surgical problem, then that surgical problem you will need a specialist who is working on hysteroscopy and laparoscopy. Medical treatments of IVF, many patients do ask whether there are any problems or complications. Well, no problem, no treatment can be 100% safe with 0% complication rates, and certainly that is true for this too. There is a 10% chances of you having twins or triplets or even higher order pregnancies. The ovaries can be overstimulated and much increased in size. That can be a problem. That can be quite life-threatening at times. There may be some bleeding or infection. The babies may deliver early, but whether there is any birth defects associated with the procedures, assisted reproductive technologies, the answer is probably no. There is no association. But late ovarian cancers in late life may be associated with the number of cycles you have had ovulation induction. So limit your cycles to not more than 12. Hysteroscopy and laparoscopy are the gold standard treatments if you require surgery. Now you might require surgery for adhesions or endometriosis, ovarian cysts, whether it's polycystic ovarian syndrome or chocolate cysts or tubal blocks, malformations of the uterus, small uterus, blocks near the uterus, foreign bodies inside the uterus, fibroids, septum. Even a narrow closed cervix can be opened up to make you more fertile. So these procedures are all done by the hysterolaparoscopist surgeon. Your success is best, and the most crucial factor for your success is age less than 35 years. Other than that, an appropriate weight, no alcohol, smoking, and very, very limited caffeine intake. So this gives you a very good success rate. If you are having stimulation of egg by medicines, you have a particular success rate, say 30 to 50%. This is improved if you use hormones to stimulate the egg, and further improved if you add artificial insemination. If you have surgical treatments, then the success rates naturally will depend upon what is the problem and how severe it is. Now, in adhesions, sometimes you get a success rate only of 17% if the entire uterus is so badly blocked off, but it is possible to open them, and as high as 60%. In endometriosis, whatever your severity, whatever your success rate, after surgery, that success rate doubles. And now we come to the last slide, how to cope with infertility. It is very important for you to discuss with your doctor whatever you have heard today, and be prepared with whatever step you are on, whether you are on ovulation induction with medicines or hormones, or you require hysteroscopy or laparoscopy. Discuss all these issues and be prepared for it. It is very important to set limits. Limits of time, like you can fix your birthday next year or your birthday the year after, or any such time limit beyond which you will not go on persisting with your treatments. You must set timeline limits. You must set expense limits. How much expense you can afford and how much you cannot. Consider all other options, whether it is using a donor sperm, egg, or even an embryo, surrogacy, adoption, or the option of not having children at all. Now consider all these options right in the beginning of your infertility, so that every time when you feel disheartened about the failure of any treatment, you always have in mind that the world doesn't end. Seek support groups, people in similar situations, discuss with them and support each other, and find ways to relax and to manage your emotional stress. Finally, I just want to say thank you, and remember that the babies of all sentient beings everywhere is as lovable and as important as your own baby. So take care not only of yourself but all people and sentient beings all around you. Thank you very much.